So our first speaker is Dr. Sandawana Majoni from Darwin, all the way from Northern Territory of Australia. He is the clinical dean and senior lecturer of the Flinders University Medical School, and his topic is Telenephrology, Closing the Geographic Gap. Thank you for coming, Dr. That's enough.
Thank you very much to the organizers of the ASN conference to invite me to present this talk on how we can close the geographical gap in care. Those are my affiliations, and I have no conflict of interest to declare. So I will go through some definitions, because some of you may not know what telehealth or telemedicine is, because it's a new area. I will go through some telenephrology applications, and this is not the technical aspect, but the clinical applications. And I'll be using throughout the presentation the Northern Territory of Australia as an example of a geographically expansive region, and a little bit on the future of telenephrology. Interestingly, the World Health Organization has got a definition which encompasses what telemedicine or telehealth is, because you can use the two words interchangeably. So it is using information and communication technologies for delivery of health care by all healthcare professionals, where distance is a critical factor. And this is actually to try to advance better outcomes for people where otherwise they would not have equal access to health care. And telenephrology is using these technologies to care for patients with kidney disease. A broad definition should include the use of web-based applications, video conferencing, remote monitoring like blood pressure monitoring, use of mobile devices like cellular phones. Telemedicine is actually as old as the discovery of the technology of communication itself. The first case of telemedicine in Australia occurred in 1873, and South Australia, as usual in this area, led the process. During the frontier wars between the Aboriginal indigenous Australian population with the Caucasians or visitors, a family was injured in Central Australia, which is 1,500 kilometers away from South Australia, and a doctor who was amongst the team managed to get some instruction on how to treat that family from a surgeon who was in South Australia. And in 1876, Alexander Graham Bell, the inventor of the telephone, actually used the telephone to talk to his assistant, Mr. Watson, who had some medical knowledge, when he poured some acid on his trousers and injured himself. And he managed to get some instructions on how to treat that burn. So that was a form of medical care through telenephrology. In 1879, in the Lancet paper, in fact, a case was published of a doctor who diagnosed a child illness over the phone. And in this paper, there's a very nice discussion on the potential use of the phone as a medium of care. And in the 1900s and 1980s, of course, the USA sending people to space, they need medical care. So they started actually this application of telemedicine with systems linked to the Massachusetts General Hospital. And I think the modern type of telemedicine was born from there. There was a bit of reduced activities in the 1980s to the 1990s, but the Americans took advantage of this and started maturing their own programs. And the VA system of care actually did a lot of work to mature, which is why probably some of your telenephrology systems, we can borrow quite a bit from them. In the 2000s and onwards, the rapid advances in science and technologies, of course, the advent of the internet, improved communication, led to the expansion of telenephrology across the globe. You can't see this very well from there, but this is just a summary of the evidence that we have. There are very few publications in this area, mainly because it's very new. So we need to do a lot of work to give some evidence to the use of telenephrology. The major messages from this table are that it's used in several countries across the world: Jordan, USA, Spain, the Netherlands, and in all modalities of nephrology, CKD care, hemodialysis care, peritoneal dialysis. And this slide shows that you actually use it in transplantation. The major messages from one of the major messages is that it improves access to care for people who live in very remote areas. It improves outcomes, patient satisfaction, but the studies were very small. And the two clinical trials which were there were very small as well, but both of them showed that survival was not different, or hospitalization was not different to standard care. So it is a modality which can be used for effective care for patients who live in remote areas. So there are several domains that can be used. You can use interactive video conferencing. I'll explain this a little in the next slide. Teleconferencing, which we used a lot before 2015, before we set up our video conferencing systems. You can use mobile phone, social media, direct calling, text messaging, and the store and forward system, which I'll explain in a minute, and the self-monitoring and management together with remote monitoring. And with remote monitoring, you can actually attach certain gadgets to a dialysis machine which can transmit information to those who are dialyzing in remote areas. And this was done in the mid-90s from South Australia to a remote area where one patient was very scared to go to hospitals. And once a video conference system was set up in his house, they actually managed to avoid him visiting hospitals frequently. So the domains can be divided into two major components: the synchronous domains, which include the interactive video conferencing, which I think is the best in our system because you use real-time communication with patients. You can use group interactions. And in our setting where we care, the majority of our patients are Aboriginal Australians, we actually use that for family communication, which is the essential part of caring for patients. And there are disadvantages, of course, in that you need a lot of technology, videos, you need the very good monitors and good computers. The mobile phone, you can actually directly speak to the patients, so it's a direct communication, but you can't see them, which actually eliminates the human interaction, which is essential for patient care from the patient feedback that we have received. The asynchronous one includes the store and forward, where you can send bulk data like laboratory results, images to an expert who will interpret them and send the results back to you. Or you can use the phone to send text messages for advice, or to patients to ask how they would be going, and you can have an interaction through that. And of course, we have sensors which can be put on patients, like BP monitors, as I have said at the beginning. One of the critical parts of a successful telemedicine program or telenephrology program is the setup of the applications. And this is just a basic setup of the program, where you have a physician in the office with the equipment where you can monitor what's coming from an examination room, which is 2,000 kilometers away. That's talking about Australia. I don't know whether you've got those distances here. And you can actually send through high-speed lines information which is real-time. You can talk to your patients, you can talk to your colleagues and providers on the other side. And this is an example of our system. This is a clinic which I was doing 2 days before I came here. And Vijay is one of my trainees. And we've got our video conferencing system. It's not yet up, but it was just about to get connected there. And we've got a very good IT system where we review all the results. and we can access the patient's electronic records. In a clinic called Borolula, which is one of the clinics I cover, it's 1,000 kilometers from Darwin, which is the city where I was based. There was the patient and the clinic chronic kidney disease coordinator, who is a specialized nurse. And of course, sometimes you've got a GP there. And you see the patient and interact with them as if you are in the same room. And there are different types of consultation interactions which can be done. And this is an example from a recent publication from NDT showing how nephrologists can communicate with primary care providers. You can use that for educational, for educating the remote specialists on how to manage kidney disease. Or you can actually do structured case-based presentations with the primary care provider. And they can ask questions and have an interaction which can actually help with the continuous medical education as part of the Telenephrology program. And this is our integrated clinic management. We do 3 types of clinics. We've got the first one, which occurs in the main hospitals. We've got the telehealth clinics, which is a completely set up program. And we've got an outreach program where we fly to the remote communities to see patients. And before 2015, we did most of our clinics through the outreach program, which was very expensive. But with the introduction of a very comprehensive telehealth program, we have actually reduced the cost dramatically, and I'll show you some of the data there. But what you need is a very good referral system, a very good primary care system where they write good letters, where you can actually triage the patients appropriately with good information. And this is a system which was developed by one of my colleagues, Dr. Abhiratna, which we call the Smart Clinic, which we use for triaging our patients. So all referrals come to a central repository, and they're actually assigned to nephrologists covering different regions within our area. And then when they are assigned, the nephrologist will open this system, click where it says assigned there, and then read through the referral letters and start triaging. And that should happen. We have got a key performance indicator where we actually make sure we do these things well in time. And then once the patients have been triaged, they are seen. We reject some of the letters if the referrals are substandard. For example, if a GP, we get some referrals where they say, please, can you form a fistula on this patient? That is not a good enough referral. So we ask them for more information. And the key part, which I actually want to illustrate with this slide, is having a very efficient clinic administration team. And in our case, we've got a senior nurse and who has got admin support. And they actually ensure that there is the efficient communication between the clinic and the nephrology service. This is very, very important because information, if you make a decision about a patient, someone has got to follow it up. They've got to remind the patients that they've got a telehealth clinic. And our turn-up for clinics has improved significantly since then. Why the Northern Territory? In fact, I was reminded by one of my colleagues, Stephen, why I think this is relevant to me. I'm from Africa, by the way, if you didn't know. And I used to run 18 kilometers to school and 18 kilometers back when I was young. So when I went to the Northern Territory, it actually reminded me of these distances. And that actually motivated me to have some interest in this type of improving care for patients because I was there. So the Northern Territory is actually a perfect storm. It has got remoteness as one of the major problems, high prevalence and incidence of rates of kidney disease in young people, poor socioeconomic status. And one of the feedback we have received from our patients is that the communication within standard care is culturally inappropriate. It's done in an environment which is far away from home. They want to be communicated to in their own environment, and this has actually made a difference to that. And these are some of the examples there's no fuel for the next 500 meters. This is in Central Australia, which is part of the Northern Territory. And this is these are some of the roads that you can use going to see people in clinics. And this is where you can land sometimes if you go for your outreach program. And when it rains, which it does quite often in the Northern Territory, these places can be inaccessible, whereas the telenephrology can actually bridge that gap. So this is Australia, if you don't know it. The blue one is actually, this is the remoteness area map, which is very useful to me actually. The blue one is very remote. The light blue is remote. And if you look at this map, and look at the next map, which is a distribution of incidence of kidney disease. And if you superimpose these maps, you'll see that most of the chronic kidney disease is in very remote to very remote areas, which is why it's critical for us to really be able to provide this care. Examples of some of the distances. Darwin here is the city where I work, which is a modern city, and Borroloola is one of my favorite clinics. We call it one of the hot spots of chronic kidney disease in the top end of the Northern Territory. It's 1,000 kilometers away from Darwin. And you can see on this side here, this is, I took this actually when we went for one of our outreach programs, and this is my colleagues, Jackie Hughes, and the team, the CKD team, who had just arrived, who had just taken a plane, who are taking a plane back from another remote community called Warui, which is about 600 kilometers away from Darwin. And we've got Kaukarinj here, which is further away. And now all these centers have got very good telehealth units. And this is me doing another clinic with one of my registrars. And at this time, actually, we were just explaining to the patient and to the nurse who was on the other side the plan. The patient needed to come to Darwin for a renal biopsy, and everything was planned there. Before we introduced this comprehensive system, they would have had to come to Darwin for all these appointments, or we would have had to go to Borroloola several times to see them. And sometimes they would not come to the clinics. And as you can see, as I was saying, this is the distribution of, from ENS data, the distribution of incident and prevalent hemodialysis patients. This is across Australia, Queensland, New South Wales, Victoria, South Australia, the Northern Territory, Western Australia, and the rest of Australia, and you can see where the Northern Territory is. That's why we really need a very comprehensive clinic management system, which includes telehealth. And we have got enough data now to analyze 3 years worth of data. We haven't finished the analysis, but a snapshot has actually showed that there's been an improvement in the service efficiency in the last 3 to 4 years, increased the service access with sometimes reduction of waiting list by 70%. And all our patients are triaged on time. They are seen on time, which is something which was impossible before. And there's been increased access. For example, one of our policies is the fistula first policy, but we've been struggling a lot because of this remoteness. That has improved a lot by 51% in the last few years. There's been improved coordination, very good planning, and our primary health care, we have been very despondent about the care that they've been, the support they've been receiving in caring for patients with kidney disease, are much more satisfied now. There's been improved education for staff. So it is really beneficial. It negates the impact of geographical distance. It improves communication with patients. It increases collaboration between healthcare providers, which is a very critical part of why we should really be encompassing it or including it as part of a comprehensive program for rural. And I think even those living in cities, we've got patients who are working, who would find it difficult to attend every clinic. You can actually set up a system like this where you can talk to them in their office at work and make a difference. It may be cost effective. I say may because we need some robust analysis of the data to prove this. It improves adherence to appointments and treatments. Several of the few studies which have been published have shown this. And in our setting, we are also beginning to see some signal of this data, of this in our results. It improves access to education for remote workforce, which is something they've been asking us. CKD coordinators, they want to be part of what we do, but that has been very difficult with the outreach and face-to-face program. It motivates the improvement of technology. In fact, our system has been improving with the feedback that we have been giving to the IT system, and it increases the uptake of new technologies for use in healthcare. Now we are moving to social media. After the clinics, we may need to communicate with our patients, and that is actually improving care. And this recent paper actually shows that, this is from the VA, by the way, there's no difference in survival between those followed by telenephrology and those followed by usual care. So what is the future? We need more robust prospective research to assess the benefits of telehealth. Improved funding is required. In Australia, we are very lucky. This is part of the funding program, and the colleges have actually taken this up. We need to increase the use of other novel and innovative technologies which are coming in, and develop complete integrated care programs informed by evidence, which should come from analyzing the data that we have now. Incorporation of this kind of work in the training of nephrologists will be very helpful as well. So in summary, telenephrology can be a key component of health, a comprehensive healthcare provision system for people with chronic kidney disease. There's need to consider the resources, of course, before you set it up. And you need to plan very carefully, because it can fail if it's not properly planned. It closes the geographical gap, it may be cost effective, and it can provide a very good collaborative framework among providers. Health outcomes may be as good as standard care, and we need to do more research to assess how effective it is. Thank you very much.
This presentation is open for questions. Gentlemen.
Thank you very much for the presentation. My name is Rashid Dawi. I am the Home Program Director of 2 units in upstate New York, Saratoga Springs, and Glens Falls. And I'm also from Africa. I'm from Algeria, and you're maybe from Nigeria. So we have been using, there is 2 places in the US that using remote monitoring. I'm also the director of the remote monitoring in Saratoga Springs. So I'll tell you a little bit about the history of the, in 1998, our team, I started with the team in 2003. In 1998, they went to Canada, Toronto, and they got this monitoring from Dr. Perotto. And so we brought it to Saratoga Springs. Then I joined my team in 2003. So we have live monitoring when we have home patient, when they dialyze themselves. We have live monitoring of their treatment live. So you can see the flow rate, you can see when they start, when they finish, the blood flow rate, you can see the arterial and venous pressure. And so we have, initially when we brought that system, we thought this system, you have to do it only 300 miles. That's what then I started 2 years ago. One of my patients went to Canada, went to Napa Valley, California, and she dialyzed herself in the hotel, so we were able to do it. So now I have patients from Sacramento, Tennessee. This trial, I have 10 patients, and from different places, from New York. And we monitor them from New York. So what we have this monitoring. We have what we call observer, like you show this in the system. So they sit to aid. We train them. There's people who come from outside, not necessarily they have any medical background. They do rotation with the home team. So they train them for 3 months, then we certify them they become observer. And so they sit on the computer from 5 p.m. until 7 a.m. and they monitor those patients. So you can see. And if there is a problem, they communicate with them. There is system of alarm. So it increases the retention rate. The patient tell us that this is like guardian angel. We offer it for patient with partner or without partner. So even who has a partner, that partner can travel, can do things that we can. So it's a unique system. So we have it in the Rogozin clinic. Another clinic has it. So my goal is to offer it to anyone. We don't have patent on it on things. We can do patent, but we don't want to do that. I want to open it to other people to use it. So if you are interested, you want to explore it, we'll be happy to show you how to do it.
Yeah, thank you very much. And I mean, it's very interesting because in South Australia, as I said, in the 1990s, they were already doing the kind of monitoring that you are referring to. This particular patient I was talking to, it's very effective, and it improves the uptake for home therapies, which is sometimes quite difficult for a lot of patients. So I agree with you there.
Just to ask you another question. You are doing like interstate monitoring from New York to California.
Yes.
Is it allowable through state to state?
There is no regulation. New York State, there is no regulation. We don't. For example, when our nurse, the observer, so for example in Tennessee, I took a patient from Tennessee. So then we have regulation. Usually, if patient is mine, I have patient that come from Boston to see me. So if there is an issue, my nurse call the patient or the aide. But if the patient is from Tennessee and belong to another nephrologist group, so the aide call that nurse who's on call and the nurse will take it. There is no regulation of that, and it's allowable because we don't make medical decision. There is another one in that state, the nurse and the doctor on call, nephrologist, that I discussed with him about protocol before. But concerning my patient, I will be the one making the decision for patients who are from Vermont, Boston to see me.
Sorry, I didn't introduce myself, Dr. Masood from Phoenix, Arizona. We have also been doing telenephrology primarily for our remote hospitals. And many hospitals in northern or southern part of Arizona, which are very remotely located, are sort of getting telenephrology input by us, and I have personally been involved in it. What I wanted to ask also is there telenephrology available to remote dialysis clinics, and has Medicare actually allowed it? Because I recently heard that something is happening from 2019. Can you tell us a little more about that, please?
In fact, I'm from Australia, so I was
I got it. I think for home hemo now they allowed that you can monitor you can bill where the patient is at home. That was the main problem. You can do dialysis, but you have to be in an area where it is designated for telemedicine, so a certain clinic. And now this rule they made it a little bit more lax, that you can have. For example, home patient, their home, they become acceptable for that. But I'm not sure if it is still for in-center dialysis. So far, it has not been, but I don't know if it has changed. There is.
I can elucidate that because they talked about the focus group yesterday. Sherry talking to me now. So if the patient is a member of an ESCO and the physician is in the ESCO, he can do telemedicine in the dialysis clinic.
There you go.
If you are not in that ESCO, then you may not do telemedicine in the dialysis clinic.
I think I heard that the Vita is allowing it in certain clinics in a few places. Yes.
Yeah, last question. Last question, please.
Yes, Eric Wallace, I'm a nephrologist, medical director of telehealth. I've been doing actually home dialysis visits. My patients in Alabama, we have 50 of 67 counties that now have telehealth up and running. But as medical director of telehealth of all telehealth at UAB, I meet with compliance all the time. And so the issue you're going to run into is that does the nurse overseeing that patient in another state, does that constitute nursing? So it's not your medical license because you're not actually doing care, but nurses are also certified by the board in the state where they're doing it. And so from a legal perspective, our compliance would say that that probably constitutes nursing care, and it could put that nurse's license in jeopardy depending on how that state actually views it. So personally, if you're doing any monitoring where you're using a nurse, social worker does the same thing, where there's states that actually require social work licensure. I would recommend that those nurses actually get credentialed in those. You're right, you don't, because you're not actually making medical decisions, et cetera, but the nurses probably do have licensure that is associated with it.
Okay. Well, sorry, we're going to have to move on. Okay. Thank you.